All right, so protecting your patient. One of the best things you can do, assuming they need to get the x-ray exam, one of the best things you can do is patient shielding, okay? A shield is any piece of material used to block, or the correct word is attenuate, a portion of either the primary x-ray beam or the scattered x-ray beam. Now the scattered x-ray beam and primary beam are different. We'll talk about that in maybe a little while. But there's different types of shields for these different circumstances. We have contact shields, including lap aprons or half shields or full lead aprons, or leaded rubber cutouts that are like sheets of lead. These are placed directly on the patient. This is why we call them contact shields. It's the typical lap apron that you have laid on you, or the full apron you have laid on you when you go get dental exams, right? Or the ones you'll be placing on your patients when we do x-ray exams. We have them in our x-ray room. You'll get plenty of time hands-on with them. There are also shaped gonadal shields. These are the triangular shaped shields in different sizes that are designed to specifically cover the patient's gonads, male or female. And there are also shadow shields. Shadow shields cast a shadow of the shield onto the patient, and they actually hang off of the x-ray tube. This is a crude drawing of a shadow shield. That little triangle hanging off the bottom is the shield. We have one on our x-ray tube in here, so when you get next time you're in the x-ray room, take a look. They don't touch the patient. They actually sit, just hang underneath the x-ray tube, and that little triangular piece of lead, you can bring it in, and it just blocks part of the x-ray beam, and you cast a shadow of what you want blocked down onto the patient. It's a way of blocking the beam without actually having the shield touch the patient. Sorry. Remember, x-rays travel in straight lines. They don't bend, right? So if you block part of the x-ray beam, it blocks it all the way down to the tabletop. Okay? So shadow shields are really effective. Shadow shields work best. They were originally designed to maintain sterile fields in surgery because all they do is cast a shadow. They don't actually have to touch the patient. All right, here comes some rules. You got to remember some certain rules. This is one of the most important rules for patient shielding. You cannot forget this one. The patient's gonads must be shielded anytime they lie within 5 centimeters of the edge of a properly collimated beam. 5 centimeters is 2 inches. So anytime the patient's ovaries or testes are within 2 inches of the edge of your light field, you have to shield their gonads. Do you think can anyone think of a circumstance where the collimated light field would be that close to the gonads and you wouldn't shield them? Coccyx? On maybe a female?
Yeah.
And why?
Because if you put the shield there, you're not going to be able to see the coccyx.
Right. So the caveat, and they put it right here, do all of this provided the diagnosis is not compromised. So the rule says put the shield on in this circumstance, unless putting the shield on would block the anatomy you're trying to see. Makes sense, right? Any procedure, so this is the only scientific indication for using a shield. This is backed by good science, and we must follow this rule. Any procedure in which shielding is not scientifically indicated, if the patient expresses any concern, it may be wise to use it anyway from a public relations standpoint. Basically, the shields that we put on them for all of the other procedures just make them feel better. They don't actually do very much. Okay? They do stop scattered radiation, but the amount of scattered radiation the patients are getting with or without the shield is minimal, nearly negligible. The shields that we put on, the lap shields, the big aprons, they really are to make the patients feel better. So don't tell the patients that, okay? If they say, I want a shield, put the shield on them, right? Put a lap shield on them when you're doing just regular exams. It makes them feel better, okay? It doesn't make that much of a difference, and it's not scientifically indicated to cover the gonads in those cases, but do it anyways. Use the lap shields, yeah.
Percentage-wise, like how much does it, like...
The shields?
Shield, yeah.
The shields block like 80-something% of the beam, depending on thickness.
Yeah.
but 80% of a scattered, blocking 80% of the scattered beam is not very, there's just not very much in the scattered X-ray beam. They're already getting the exposure in that one body part, so that's already a bit more than the scattered radiation they would receive. So it's very minimal. So the shields don't do very much. That's why they say they're not scientifically indicated. Yeah. Now, if you were getting exposed all the time to scattered radiation, then you should wear a shield, which is why X-ray techs wear shields when we're working around our patients, right? So it's useful for us to wear them. It's not actually scientifically indicated to wear them when we're doing anything else, right? But we put them on our patients to make them feel better. Yeah. And you'll see all kinds of goofy things. People will like turn their heads like that, like that's gonna matter. Or close. I love the closing the eye. They close their eyes like that. It's not gonna make any difference, right? But it makes people feel a little bit better. So do everything you can to make them feel better, right? You want your patients to be comfortable. That's a huge part of healthcare, is making sure your patients are comfortable, right? So even though we know it doesn't make a big difference, if it makes them more comfortable, that matters, right? So yeah, we have thyroid shields, we have gloves, we've got the full aprons. Put on whatever makes them comfortable, okay? And I have no problem with that. And you don't need to go, well, actually, it doesn't really, you don't need to just put the shield on them. Okay. So here's where I got that number from. Leaded aprons or leaded rubber sheets. The general effectiveness is approximately 85%, but they range from 66 to 99% effective, depending on the thickness of the shield and the kVp. Remember, kVp voltage makes your beam, changes the penetrating capability of the beam. So higher kVp, more penetrating, the shield will absorb less at higher kVp. A half a millimeter of lead is 88% effective at 75 kVp. That means if you put it in the path of the primary beam, 12% of the beam gets through. So no shields block everything, right? Even the thickest shields we have can block up to 99%, but will not block 100%. They're just not possible. Your lead aprons that are not designed to be used in the path of the primary beam, the lap aprons, those kind, are only required to be 0.25 millimeters thick. So 0.25, a quarter millimeter. Most of them are a half of a millimeter just because. Okay, so twice as thick just because. Gonad shields, gloves, and the aprons designed to be used in the path of the primary beam, all of those are required to be a half of a millimeter of lead thick. Okay, you'll look, and like on clothes, how they have the little washing tag on your clothes and stuff. Well, your shields have a little washing type tag on them. Don't wash them, but they have a little tag on them. That tag says the lead thickness of that shield, the lead equivalent thickness. And that's another thing that's important. Your shields are not likely going to be actually made of lead. Now they can be, but lead is expensive, it's easy to damage, it's very heavy, right? So often the shields are made with what's called lead equivalent. They just have other material that is equivalent in its attenuation, its X-ray stopping properties, but it's not the same. You guys out here? Yeah. Thank you. It's not the same type of thing. It's just a different material that absorbs X-rays just as well. So we call it lead equivalent. All right, policies regarding pregnant patients. What did you guys learn about the risk of radiation exposure during pregnancy?
It can affect the baby.
It can affect the baby, right? Very high exposures can cause mutations in utero, right? And even low exposures to the gonads before conception can cause genetic mutations, right? All of these can manifest as things like birth defects, congenital defects, right? Or worse, right? But the point is that radiation to a developing embryo or fetus is harmful, or can be harmful, right? We want to minimize that. Now, it's most harmful during the first trimester, during the first 12 weeks, less harmful after that, but anytime during pregnancy, the fetus is still several times more sensitive to radiation than an adult. So, the provision of patient education materials is strongly recommended. Brochures, videotapes in the waiting areas, posters on the walls, talking about if you're pregnant, talk to the doctor about it, right? That way this doesn't like skate past us and we find out that she's pregnant until after the x-ray is taken, right? Ask all childbearing age females if they could be pregnant. Notify the radiologist or supervising tech or your ordering physician if she says, I don't know, or if she says yes. If she says anything else but no, you need to talk to the doctor, right? Like, I'm not sure. Talk to the doctor, okay? What can we do in the medical setting to check for pregnancy? We can do a urine pregnancy, right? Easy, takes 3 minutes, right? Get a urine sample, takes 3 minutes for a result. It's quick, and often we do it at no charge to the patient if it's for the x-ray exam, okay? I mean, depending on the type of facility, but like, I know our urgent care, they won't charge for a urine pregnancy if it's for an x-ray. If it's for anything else, we charge, but if it's for radiology, we don't do it. So we'll just check it, right? We want to make sure, right? So we're going to do the best thing we can for our patients. What's the childbearing age range? Like, when does it start? When do you think it ends? Let's talk about when do you think it starts? When does puberty happen for females, let's say? What'd you say? Like 13, that's a pretty good age range. I've seen as young as 9, right? So, and so that's the low end. That's some stuff on the low end. Let's talk about the high end. When does menopause typically happen? About 50-ish, right? As late as 60s, maybe later, right? So that you don't have to remember like all these different beginnings and ends, I will just tell you 8 to 80, okay? From age 8 to age 80, ask all the females if they could be pregnant. And yes, every female above the 50s who's gone through menopause is gonna, kind of scoff at you for asking her. Just ask her, okay? It can't hurt, okay? And yeah, I'm sorry, you have to ask the 8-year-olds too, okay? Is there any chance that you're pregnant? And they'll, big wide eyes, what do you mean pregnant, right? They're 8 years old, they don't know anything about that. You gotta ask, okay? There can be sexually active and sexually mature, potentially 8-year-olds. I mean, that'd be right at the very, very beginning and very, very rare, but it's possible, right? And because it's possible, it means it can happen. And things that can happen, we should probably double check, right? So yeah, there's 2 that I remember very good, and they both work. Just both of them remind you to check the very young and the very old. 8 to 80 or 6 to 60. 6 to 60 is kind of on the low end, on the bottom side of it, but I like 8 to 80. That reminds me that check pretty much everyone, right? Yeah, just check them. Just ask. And the young ones, ask them when their parents aren't around. Okay, you'll likely have them in X-ray when their parents aren't around. You're not going to get a straight answer out of a kid who's sexually active if their parents are around and they're like 10 years old, right? They should not be, but it happens, right? So keep an eye on that. Make sure you're asking anybody who's in the childbearing age range if they could be pregnant. And you want to know when the last menstrual period was, right? That's one question we ask all the time. If they know when their last menstrual period was, didn't miss one, not likely that they're pregnant, but check on that. For non-urgent procedures, a policy of selective scheduling can be used. Have X-ray procedures done within 10 days following the onset of menses. The onset of menses, the ovulatory cycle, the onset, day 1 of like the menstrual bleeding is day 1 of the ovulation cycle, and by day 14 she's ovulated. So within that 10 days she hasn't ovulated again. She's no possible way she's pregnant. So within 10 days of the beginning of the last menstrual period. By the way, make sure you're asking the beginning of the last menstrual period, not the end, because when you ask a female when was your last menstrual period, almost always the most important part of it for her was when it ended, not when it started. But we don't care when it ended, we care when it started, okay? Because that marks the first day of the ovulatory cycle. So ask for the first day of the last menstrual period, and you'll get a good answer on when that happened, hopefully, and then you can use that for making determinations on if you should or shouldn't take the X-ray. Okay. When a radiation exposure occurs to a developing embryo due to a pregnancy unknown at the time or to an emergency or during an emergency procedure, the embryo dose can be reasonably estimated at about 30% of mom's entrance skin exposure, because she's going to absorb some of it, right? The baby doesn't get all of it, they get some of it, about 1/3. If in an emergency, like a car accident on a pregnant female, and she's unconscious, unresponsive, they can't determine if she's pregnant right away, they have to get her into CT because she's like bleeding out or something like that, they got to do it quick. They're going to send her into CT, do a whole body CT scan, and she's going to get a whole lot of exposure in that CT scan, okay, with no shielding. And in those cases, if the dose exceeds 100 milligray, abortion should be counseled depending on what stage of gestation she's at, right? But that's assuming she survives it to begin with. In order for them to be doing that, these have to be very, very life-threatening things. So they say abortion should never be counseled by medical personnel if the estimated embryo-fetal dose is less than 100 milligray. Above that, we provide counseling on what are the potential risks that happened during this emergency. We had to do it to save you. Here's the risk of doing that. Here's the risk to the fetus. They say fetal exposures above 250 milligray pose a substantial increase in risk for congenital defects. If it's after the first trimester, all of the skeletal stuff has already happened. What you're most at risk for after the first trimester are cognitive disabilities, mental retardation. In the first trimester, in the first 12 weeks, there's big risk for malformation of the skeleton or nervous system or any of the organs of the body. So bigger problems happen early on, less severe problems happen later. But either way, they need to have some sort of counseling after a large exposure in an emergency like that. Okay, so very rare, does happen. We have an x-ray here at the school somewhere. I don't think it's in here right now. I've shown it to you guys before, a plain film of baby, in full-term baby in the tummy of a pregnant mom. Yeah, is it up there on the view box? Yeah. So if you haven't seen it before, you can come up at some point in the class and take a look. It's on the view box up there. But it's a full-term baby inside of a pregnant mom, and they had to take an x-ray plain film image to look for fractures and things like that after a car accident. So these things happen for sure. All right, let's cover some now equipment guidelines that help keep our patients safe. Some of this you guys have had experience with because we talk about it in the x-ray room. For example, by the way, these are important guidelines. All x-ray machines have to follow these guidelines. One of them is all exposure switches, anything that makes the x-ray beam turn on, has to be what's called a dead man's switch, okay? A dead man switch is a term taken from train engineer terminology where the train engineer, in order to keep the train moving forward, had to keep their hand on the control, okay, the speed control. If they happened to become a dead man and die, right, fall on the ground, their hand comes off the speed control and the train stops, okay? In x-ray terms, our exposure button's a dead man's switch, which means if we set something like a 1 second exposure, we've got to press that button down for that entire time, okay? If you set a 1 second exposure, but let up before 1 second passes, the exposure will terminate before the timer runs out, okay? Once you hold it for the full exposure time, any time holding it after that, the exposure has shut itself off. You have to hold the button for the minimum amount of time the exposure happens. If you let up before that, exposure stops. Dead man's switch. Guidelines for filtration. So, good. We mentioned what filtration was. It's a piece of aluminum usually placed in the path of the x-ray beam that stops low energy x-rays from getting out of the x-ray machine. In fluoroscopy, which we don't do, but let me read it, any machine operating above 90 kVp has to have 3 millimeters of aluminum or aluminum equivalent. You can use anything as long as it's equivalent to 3 millimeters of aluminum. Here's what you need to remember. Our machines, which are overhead units, capable of operating above 70 kVp, have to have 2.5 millimeters of aluminum. That's the amount of filtration our units are required to have. Now this is built in and added, but up to 2.5 millimeters of aluminum. This is the stuff that filters out the low energy x-rays in the x-ray beam, stopping them from reaching the patient. There's a minimum distance that our x-ray tubes can get to the tabletops, okay? Your collimator boxes are these big blocky things for a good reason, okay? They prevent you from lowering the x-ray tube to where it touches the patient, right? There's the box in between the patient and the x-ray tube, even if you brought it all the way down to the patient, okay? So the minimum possible distance, 15 inches for fixed units, 12 inches for mobile units. We'll often have on mobile units, it's hard to see in this, but let me zoom in, the little clear plexiglass cone gets us that extra distance. And on fixed units, some have rails underneath the collimator box. That's to space out, to make sure there's enough distance between the source of radiation and the skin. The black arrow is pointing at those rails right now. So we have a minimum distance now. In fluoroscopy, which is video x-ray, don't worry too much about this, but there has to be, because you don't do fluoroscopy, right? There has to be a 5-minute cumulative timer. Every time we turn fluoroscopy on, it adds time to the timer. Once 5 minutes hits, we have to have an audible signal that lets everyone in the room know we've hit 5 minutes of fluoroscopy time. It is then the radiographer's job, my job, to turn to the radiologist and say, we're at 5 minutes of fluoro time, by the way, right? What if they're in the middle of a surgical procedure? Stop the procedure? No, absolutely not, right? Finish the procedure, so the radiologist will go, uh-huh, and then they'll keep going about what they're doing. Every time we accumulate another 5 minutes, I tell the radiologist, 5 minutes has passed, and they go, uh-huh, and they keep finishing their procedure, okay? It's just a reminder that we've reached the 5-minute timer, and every time we reach another 5-minute timer, we got to keep an eye on that. It's because exposure levels are adding up and adding up and adding up, and I got to keep letting the radiologist know, because they're focused on what they're doing. I got to keep letting them know, hey, we hit another 5-minute timer, hey, we hit another 5-minute timer, just as a audible reminder. That way we all are consciously acknowledging that we're passing that 5 minutes and continuing on. We're all okay with it. All right. This is not that important for you guys. Fluoroscopic collimator shutters shall be visible on the TV monitor at all times fluoroscopy is engaged. Don't worry about that too much. I'm going to skip this next fluoroscopy guideline because, again, limited text don't do fluoroscopy. Yeah, I get to skip that, skip that, skip that. I'm going to go to here, C-arms in surgery. A C-arm is a type of x-ray machine. It is a fluoroscopic x-ray machine, but it's a type of x-ray machine shaped like a giant letter C. It's used in surgery, and C-arms allow you to get the x-ray machine very, very close to the patient, which means the patients can get very, very high levels of radiation exposure and can actually get skin burns. Severe radiation burns occur with modern C-arm units. So quick quiz, how much radiation is required to cause a skin burn? It's going to be a partial body exposure. It's in sieverts. So plug your ears. Sieverts is the unit we're using. It's a lot higher than that, like 1,000 times higher than that. It's 2.5 sieverts. So remember, 1 gray or 1 sievert is enough to cause death if it's to the whole body. But for partial body, you can go much higher than that without causing death, right? So 2.5 sieverts causes skin burns. We can go above 2.5 sieverts very easily in fluoroscopy, and especially with C-arm, because the C-arm X-ray machine part of it can get very, very close to the patient. It's usually underneath the patient, which is why I'm gesturing from underneath, but it can get very, very close to the patient's body, and the X-ray tech really has to keep an eye on that. My C-arm is a big C-shaped thing, and if I move, one side of it is the X-ray machine, the other side of it is the image receptor, and as they're an equal distance, they're a fixed distance apart. So if I move the image receptor away from the patient, the X-ray machine comes closer to the patient. If I move the image receptor closer to the patient, the X-ray machine part of it moves further away. And so they're a fixed distance. So I got to try to manage the distance that my C-arm is from the patient. And let's see some numbers here. So this is a physicist's estimation. An ion chamber, which is a radiation detection instrument, measured an exposure rate of 30 to 40 milligray per minute. So you can take that and multiply it by 5 minutes and see what it would be after 5 minutes. But 30 to 40 milligray per minute at a distance of 75 centimeters from the X-ray tube. To allow for a sterile field, the image intensifier is moved high above the patient. Again, image receptor and X-ray tube are fixed distance from each other. So if I need to move my image receptor up, the X-ray tube is going to come closer to the patient. It's underneath the patient. Patient's here-ish. And we come up with the X-ray tube and higher with the image intensifier, image receptor. So in order to get the image receptor, or as they're calling it, the image intensifier, high above the patient, the X-ray tube comes very close. With the X-ray tube at 30 centimeters, the estimated entrant skin exposure for the patient is 180 milligray per minute. And then you can multiply that by the 5 minutes of fluoro time that was typical. And it's been estimated that surgeons adopt a target maximum exposure to the patients between 200 and 400 milligray, even for urgent situations. But you can see at 180 milligray per minute, multiplied by at least 5 minutes, it's going to add up very quickly, right? It's almost a full gray, right? So it's shy of that, but it's almost a full gray at 5 minutes of fluoroscopy time, which is quite a lot. And you go to 10 or 15 minutes of fluoroscopy time, and now you're well into the range where you can start causing skin burns. Okay? So these things add up very quickly. Distances matter a lot, the distance that we are from the source of radiation. And in C-arm, this C-shaped thing that we have is such a, like a fixed thing that if I want to move my receptor farther, my x-ray tube is going to end up closer to my patient. So I have to keep an eye on that. Luckily, that's not a concern for limited radiography. It's just something that you should keep in mind. Okay. Let's see some other things. Some other current issues in radiography that we thought about. Current as in, you know, later part of the 20th century. But anyways, in the late 1990s, a study conducted by the Food and Drug Administration Task Force came to the following conclusion. So FDA has a lot to say about the use of medical radiation, right? We're on the drug side of it, okay? Even though it's not a drug, it's used for therapy. Anyways, FDA has a lot to say about what we do. They say in cardiovascular, interventional radiology, angiography, and pain management procedures, new techniques requiring longer exposure times and higher dose rates to image smaller objects are now resulting again in severe burns and lesions. Basically what they were saying was, by that 1990s study, was that because we got all this fancy new technology, we're using it in useful ways, but the ways we're using it are posing high risks to the patients. Because we have to use high exposures, because we have to use long exposure times to do all this fancy medical stuff that we're doing, patients are ending up with higher dose rates for exams, and that is adding up and increasing patients' exposures. And remember, medical radiation accounts for 51% of the radiation an average person receives in a year. So now we're increasing that side of it, increasing the exposure to entire populations. Safe Medical Devices Act of 1990 requires reporting to the FDA of serious radiation injury or death. And the FDA task force identified a list of high-risk procedures, all of which present the possibility of exceeding 100 minutes of fluoro time. Remember, 5-minute alarms, right? That alarm's going to come on 20 times during a 100-minute procedure. 100 minutes of fluoro time or more at 20 to 50 milligray per minute, which comes out to quite a lot. You can add that up pretty quickly. 20 to 50 milligray per minute for 100 minutes. It's going to add up very, very fast, right? Here's an estimate. At 4 rad, which is different than the gray, but don't worry about it. At 4 rad per minute, 100 minutes of fluoro time would deliver an entrance skin exposure of 4 gray to the patient. That 4 gray is a special number. What's that number in when we talk about like radiation injury, what's that 4 gray associated with? If given to the whole body. Death to half of the population within 30 days, right? It's a lethal dose, right? So if I gave all of us in this room 4 gray to the whole body right now, right? Half of us die within the month, okay? Said in another way, if I give just one of you 4 gray right now, you have a 50% chance of dying. So it's the same thing. It's saying the same thing. Half of the population dies, or if it's just to one person, they have a 50% chance of dying. It's a coin flip chance of dying, right? I don't want to take a coin flip, right? That's a pretty high chance, 50%. So 4 gray is quite a lot. Just a small reminder, though, this number, 4 gray from some fluoroscopy procedure, is not going to be whole body. It's going to be partial body, but even partial body at 4 gray, that's enough to cause serious skin burns, skin lesions, cause chromosome damage, just a number of bad things, even if it's not to the whole body. So it's still harmful. Other high-risk procedures, or some high-risk procedures identified by the FDA that we don't do but might be worthwhile just to hear and have, you know, in your back pocket. Percutaneous transhepatic cholangiography. Big long name. It deals with the gallbladder, right? And anyways, it's a case studies showed an average time of 51 minutes of fluoroscopy beam on time compared to 7.1 minutes, which is typical for like angiography. So 4 rad per minute, 51 minutes. That came out to an entrance skin exposure of 2.04 gray for that procedure. It's underneath the level that causes skin burns, but it's very close, right? It's a lot of exposure nonetheless. Other procedures, they don't give you the numbers for these, but other procedures that are identified as high exposure, high risk, radiofrequency ablations, and stent placements. Stent placements, think of blocked artery, right? Place something in the blocked artery to open it up, a stent, okay? It's angiography, uses a lot of exposure for to do those procedures. So the FDA recommends the following actions for things that are considered high-risk procedures. Recording in the patient's chart. So basically what they're recommending is good documentation, right? Recording in the patient's chart, the field size used, the body part radiographed, the technical settings, and the estimated dose. So a radiographer would be able to do that. Informed consent from the patients on the possible radiation effects. Why do you think it's important for the patient to have informed consent? Yeah, so they can say yes or no in an informed way, right? Informed consent, remember, involves giving the patient, here's what we want to do for you, here's the benefits, and then here, importantly, here's all the risks, right? And here's any alternatives. The patient then can make an informed decision. Customized protocols delineating when the use of high-level fluoroscopy should be allowed. Maximum allowable cumulative fluoro time, which is always subject to updating. If a doctor is in the middle of a surgical procedure and they've reached their maximum allowable fluoro time, they're going to keep going, right? But because they have to finish the procedure. But we should have some maximum allowable time written down. And the credentialing of all fluoroscopists, including the medical doctors. So documenting who's got what type of credentials, making sure we're all credentialed professionals doing the jobs we're supposed to do. The FDA also identifies adolescent and pediatric CT scans as an area of concern. Why do you think it's a concerning thing to X-ray, CT is a type of X-ray, to X-ray young children, adolescents and peds? Why do you think it's a concern? Relative to like adults. Right, and what do we know about developing people and their sensitivity to radiation?
Your cells are highly mitotic and non-differentiated,
Which makes them
more susceptible to change.
to harm from radiation, right, than adults, yeah? Children, no matter what age, are still at a higher risk of radiation damage than adults are. CT scanning has been identified by the FDA because CT scanning, by the way, CT stands for computed tomography. It's a cross-sectional slicing images of the body. CT scanning has been identified because it's one of those exams that gives a lot of radiation, okay? Where plain film X-ray does not give very much, CT scanning gives quite a lot. And so we worry about it for children. So they say due to inappropriate and excessive referrals by physicians, particularly in the emergency department for CT scans. Doctors love CTs because they give a lot of information very, very quickly. It takes like 45 seconds to do a CT, and they get a ton of info very quickly. But, you know, anytime you're getting a ton of info very quickly, there's gonna be a risk associated, right? The way we're getting a ton of information very fast is by using a lot of radiation for our patients, right? So, doctors sometimes default to CT when just a plain film X-ray would have been just fine, right? And would have given hundreds of times less exposure. So doctors are kind of needing to take a step back and you know, reassess when it's appropriate to use CT. You another small reason why CT is used a lot, aside from the huge amount of information, is doctors can be pressured into doing imaging that brings the hospitals more money. Okay, if a doctor has to choose between a procedure that would give information and doesn't cost that much money, and another procedure that would give more information and also cost more money, they can be pressured into doing the stuff that costs more money because the hospitals like bringing in money. So there's a weird like political administrative side of it too that we don't think about that often, but it's there. It's an important consideration. So and anytime something's in-house like that, like CT is usually in-house, the money's kept in-house. So anytime they are able to do that, they bring in more money for the facilities. So and I'm not saying that all doctors do that. I'm not saying anyone does it regularly, but it's a consideration and it does happen. So something to think about. Okay, let's move on. I mean, it's more, the urgent care is going to get more money if they do the x-ray in-house versus, shipping it out of facility, which is why we like to have our x-ray machines, functioning in facility. So similar idea, right? They're not going to refer you out for your x-ray if they can do it in the urgent care setting. It's similar concept, but in the hospital, because we have all of these different imaging modalities, some of them are very expensive, some of them are not very expensive, and they give maybe equivalent-ish information. Sometimes the doctor's going to err on the side of, the more money for the facility kind of thing. So even at the detriment of the patient's exposure. So it's because they're getting a lot of information very quickly too. So there's a lot of things that they're considering, and the administrative side of it is got to be one of the considerations that they make. So probably shouldn't be the main one though, right? Okay. Nextly, a second cause the FDA identified for adolescent pediatric CT scans as an area of concern is the failure of CT radiographers to reduce the milliamperage. Milliamperage, remember, is a number that tells us how many x-rays we're making, used for the adult. So we're taking and leaving the machine at adult settings and using them on children, which is obviously too much, right? So instead of adjusting downward for patient size and weight and the anatomic part, so the recommendation is for CT radiographers, reduce the x-ray tube's current according to weight, size, and anatomy, establish technique charts like we have in our regular x-ray rooms based on part, weight, and size. Most are built into the machines. Increase the table increment or pitch to reduce the number of slices taken. Basically, this is, I think you probably all have like a mental picture of what a CT machine looks like, even if you've never been in one or around one. There's a table that moves into the machine and then out of the machine. The speed at which the table moves in and out has an effect on how many images or how many slices are taken of the body. And if we can minimize the number of slices, we can minimize the amount of exposure. So they say an estimated 33% reduction can be in images can result without a loss of diagnostic information. So it's useful. Lastly, the radiographer, you guys, is frequently the person present with the most expertise in radiation protection. Radiographers and their organizations must take a more active role, show more leadership in preventing unnecessary patient exposure. You guys are the ones with all of the knowledge on the use of radiation. You now will know how much radiation is used for every exam, how to minimize radiation use during exams. So you have your hand on the control, quite literally your hand on the control for this, right? And you have your hand on the control for 51% of the amount of radiation people are going to receive in a year. So you're controlling the majority of the radiation any one average person receives. If you can minimize it, you can minimize exposure to entire populations and, have a role in making for a healthier, population of people, right? Less exposure to people makes healthier people. So that's the idea. We have a big effect, and everything we knew matters, right? We can lower patient doses in the ways that we talked about today. So